to all of those who are watching the recording. Welcome. So before we get started, it's going to be recorded, and Dakota has that going. So this webinar is going to be about creating inclusive clinical environments for LGBTQ plus clients. My name is Annie Romano, and I'm the social work intern at the Sorenson Legacy Foundation Center for Clinical Excellence. And I will be the moderator for today's webinar. Before we get started, we respectfully acknowledge that Utah State University is a land-grant institution, and our activities throughout the state of Utah do take place on tribal ancestral lands. These lands have been carefully stewarded by the Goshute, Navajo, Shoshone, Paiute, Ute, and Ute Mountain Ute tribes. We offer our respect and recognition to their elders, past, present, and future. So I'll provide a quick introduction to the Sorenson Legacy Foundation Center for Clinical Excellence. We kind of abbreviate it as SCCE before introducing Sean. The Sorenson Center consists of various clinics and professionals, and you can see a list of our services here. If anybody would like any more information about any of these services, you can contact me via email, and that is right there on the bottom, or the office phone number, which is posted right there. So again, this webinar is being recorded. During the presentation, please remain muted. And if you have questions, feel free to send those in the chat or privately to me. We will have a Q&A with Sean, and the webinar will be sent out. The recording will be sent out, and it'll be posted on the College of Education and Human Services YouTube page. All right, so introducing Sean. Sean Weeks is a fifth-year doctoral candidate in school psychology. It's in the PhD program here at Utah State University. He also has a Master of Science in Psychology from Utah State University and a bachelor's degree in psychology from the University of Kentucky. Sean has worked with USU's Office of Inclusion to develop allies trainings for the psychology department. He's also worked as a therapist for the Utah Pride Center and a therapist in the SCCE's Gender and Sexuality Clinic. He now works to consult with schools and rural communities to support underserved student populations. Sean has published research on minority stress in LGBTQ plus adolescents and co-authored a best practice manual for clinicians working with LGBTQ plus individuals with ASD or autism spectrum disorder. And Sean, I will go ahead and turn it over to you.
So Annie, thank you for introducing yourself. I was wondering if each of us could also go around and introduce ourselves. You kind of introduced me, but my name is Sean, and I'm in my fifth year of the school psychology program here at USU. My pronouns are he, him, his, and I'll be your presenter today. Dakota, do you want to introduce yourself?
Yes, I am Dakota. I'm a certified social worker. I'm working on my licensure to become a licensed clinical social worker. I work here at the Sorenson Center, doing a whole bunch of different things, including therapy, managing our social media, putting on webinars like this, etc., with a focus on doing interprofessional work. And my pronouns are she, her.
Thank you. And Elizabeth, this is the only time I'll put you on the spot, I swear, but do you mind introducing yourself and maybe just your name and what you do?
Sure. I'm Dr. Elizabeth Smith, PsyD, and I work in a group private practice. My pronouns are she, her, and I'm really excited to be here for your presentation.
Thank you so much, Dr. Smith. And all right, so I'm hoping that this will be decent conversation because that's how this was designed. We have a small group. So I just want to state before we jump in that I kind of expect people to be at different developmental levels when we talk about these things. So just for everybody to be kind and know that this is a learning environment. So if you can't ask genuine questions here, then I don't know where you can. I don't think that'll be a problem, especially with our small group. I assume everyone has at least some very basic knowledge, but this is still a beginner presentation. Also, this is all to say I may make mistakes during this. So if anyone wants to correct me, by all means, please do. You can write it in the chat, or since there's so few of us, honestly, you could even unmute and jump in. I will not be offended. But if you do write in the chat, Annie is moderating, so I think that she can also stop me or hold it until the end, whatever we're most comfortable with. But what I'm going to be presenting on today are how to create LGBTQ plus affirming clinical environments. And this is adapted from the manual that Annie had mentioned, where we were looking at best practice with LGBTQ plus individuals who are also autistic. And I'd like to also mention the other authors on that. Erica Ficklin, who's in the combined clinical counseling program here at USU, Janine Forsyth, who's in public health at the University of Wyoming, and Teresa Gabrielson, who is school psych faculty at BYU. All right, so the first half of this is going to be just some pretty basic information on why this is important. So we'll jump in with stats first. And a new poll out from Gallup, I think it just came out a couple months ago, are showing that about 5.6% of all adults are identifying as LGBTQ right now. And I think that maybe a lot of people are like, well, that's not that many. I thought it was 10%, because the number 1 in 10 has been thrown around a lot for a while. And I think what it is it comes down to differences in generations. So that 1 in 10 was considered true for millennials, but Generation Z now, I think, and this is pretty astonishing, the number has skyrocketed. So about 16% of Generation Z, or our younger generation, identify as LGBTQ, or about 1 in 6 people in Generation Z identify that way. So a lot of the people that are walking into your clinic, or whatever space it is that you work with clients or patients, may identify this way. So having this common knowledge is important in understanding how to create a space that's accepting and affirming for people who are part of the LGBTQ communities. You can kind of see how it's broken down across generations. And I'm curious if anyone has ideas as to why we might see the traditionalist generation with 1.3% of people identifying this way, whereas Generation Z, we've got about 16. And those numbers just pretty steadily increase, and then skyrocket in those last 2 generations. Any ideas as to why that might have happened?
I think there's definitely more acceptance. I was having a conversation with my grandparents who were born before 1946, and they were talking about how, like, oh, there was no one growing up who identified as LGBTQ, and you know, and it was like, well, it wasn't really an option for most people to identify that way. Like, it was just unsafe. And it was just kind of interesting because my grandma had mentioned that, like, oh, there's only 2 people in my graduating class who, like, didn't get married. And it's like, I wonder why that is. You know?
Yeah, absolutely. And I think a lot of this has to do with representation. So unlike maybe some other marginalized groups where it's more contained to individual communities, we don't really know or can control where people who identify as LGBTQ are going to pop up. So it's likely everybody knows somebody, at least somebody, who's close to them, whether that's family or friends who identifies this way. But Dakota, like your grandparents, they might not have known that before. And so as the representation increases and we start to see people that we know come out and see them being treated okay, then it kind of gives others the hope that maybe I'll be treated okay too. And it really kind of set off this explosion. And some scientists have mentioned this change in social perceptions, at least in America, as being the most drastic change that's been recorded. And in about 30 years, 25% of people in America thought that same-sex marriage was okay. to where we are now, where it's almost completely flipped, and about 75% of Americans think that same-sex marriage is acceptable. The interesting thing, I mean, I think that this number will continue to increase. I had talked about how I worked with the intersection of autism and the LGBTQ communities. And the numbers, the rates within that intersection or within that autistic community are much higher. They're thinking about 40 to 60% of people who have autism identify this way. And I'm curious, last question on this slide, if anyone has a guess as to why the numbers might be so high in communities of people with autism.
I feel like this is a trick question for me because I know that you presented about this in a setting in which I was there, but I don't remember what the answer is.
All right, that's fine. I'll give it away for the sake of time. But the theory, so there's actually a lot of theories, but one theory I think that stands out most, especially when we're thinking about how the numbers are increasing across generations broadly, is that a lot of autistic people don't really prescribe to what society decides is normal, or the stigmas that might be connected to social norms or social attitudes. And so those 40 to 60% might be a more accurate representation of America overall. All right, any questions on this slide before I move on? Okay, so I want to go over just a few basic terms. There's so many, but these ones I think are going to be used throughout the presentation, so I just want to touch on them real quick. We have sex assigned at birth, which is the sex so your genitals that you're born with when you're young, when you're a baby. Intersex is for individuals who are born with any of several sex characteristics, and this could include chromosome patterns or genitals. Cisgender is when your gender identity matches with your sex assigned at birth. Gender identity is how you feel, the gender that you identify with internally, and doesn't have anything to do with your sex assigned at birth, though it could. Transgender would be when your gender identity and the sex assigned at birth don't match. Pansexual, I threw this one on here because working with young people, it's popping up so much. I hear it all the time now. And pansexual is basically attraction towards people regardless of their sex or their gender identity. So it doesn't matter if you identify as male, female, cis, trans. If I like you as a person, then there's a romantic interest there, or at least a potential for it. Questioning is for people who are in the process of figuring out their gender or sexual identity. And queer, I threw this one on here too, because people always ask questions about the word queer. Can I use this? I thought this was offensive. And I think that this right now is mostly considered an in-group term. So it as a way to kind of take the word back. Generally, it's an umbrella term for anybody who's kind of identifying anywhere on the LGBTQ spectrum. But if you're not part of the community, it's probably safest to keep it out of your mouth unless a client or somebody asks you to refer to them that way. And I think there's still a pretty big generational divide in the use of this term. I know that a lot of older people who are LGBTQ still cringe and hate hearing the term because it was really used as ammunition against them throughout their lives. Are there any other terms that people have heard but maybe aren't familiar with? All right, well, if you think of some, please throw it into the chat. And I may not know the answer, but we can talk about it.
Sorry, were you asking about terms that we have heard that we're not as familiar with, or terms that we're not on there?
Yeah, terms that maybe you've heard, but you're curious about. So not just listing anything that wasn't on there, because I know that that list is expansive. More of just things that maybe you're curious about.
So I work actually with a lot of autistic individuals and LGBTQ identifying individuals. And one of the terms that often comes up is nebular sexual.
You said nebular sexual?
Yes.
That is one that I have never heard before. Do you know what it means? And would you be willing to share it with us? Or did you bring it up because you're not sure?
Well, I brought it up because the way that it has been described to me and the way that a lot of people understand it to mean is that it's a very popular term within the autistic community, and that it essentially is about understanding romantic ability or romantic presence versus just friendship.
Interesting. Well, thanks so much for sharing that with us. That is one that I've never heard.
Yeah, so the nebular romantic or nebular sexual comes up a lot in the neurodivergent community. And so I was actually going to see if you might have more of an understanding of how many individuals may be gravitating more towards that in comparison to some of the other identifications. But it
Yeah,
seems like an area for more research.
exactly. Yeah, absolutely. And I'm guessing by my response, you're probably realizing that I don't have an answer to that question.
Yeah.
And I'm not sure how recently you've been hearing that more and more. It was maybe 2 or 3 years ago that we were working on the manual. But I personally never came across that one. So thank you for sharing that. So still on the concept of terminology, I want to talk a little bit about what these different terms might actually mean. I'm going to try to pull up a laser pointer and see how that looks for you. Because a lot of times people get confused in the difference between gender identity, gender expression, sex assigned at birth, who we're physically attracted to and who we're emotionally attracted to. And I think the main confusion might be that all of these things are connected or need to be connected in the way that we understand them through a heterosexual lens. But the truth is that all of these things are separate, though they might be correlated, and can fall on a spectrum. And the spectrum is something that we've known about for quite a while. I think if most of us have probably heard about the Kinsey scales, which have been around for a long time. And I think Kinsey had put forth, what, a half a century maybe ago or more, that none of us are maybe fully to one end or another, or at least very few of us. And so when we look through this, this unicorn gives us a good idea of where each of these things fall. So gender identity is the way that we feel. So it's got it up here as like a little thought bubble. And then the different genders that we're familiar with: female, woman, girl, male, man, boy, and other. And people can fall anywhere on any of these. Gender expression, which is represented by this little bubble, kind of saying the whole unicorn here, is how we show that, whether through the makeup that we wear, or the hairstyles, or the clothes. That would be our gender expression, which could be anywhere on the spectrum of feminine, masculine, or other. And then sex assigned at birth, which we talked a little bit about on the other slide. And that's down here. This has to do with our genitals. And we have female, male, and intersex. And this is the box that a doctor is going to check when you're born. And then physically attracted to and emotionally attracted to, again, falling anywhere on these spectrums for who it is that we might have these attractions towards. And people can really be anywhere on this. I think one of the biggest issues that people come up with, and especially parents for younger kids, when I was working at the Pride Center, I ran a support group for parents of transgender youth. And parents really had a lot of trouble getting over the difference between sex assigned at birth and gender identity, not understanding how those two things can be disconnected. And they are correlated. But one thought experiment that I actually heard while working at the Pride Center, but then worked really well with the parents that I worked with to make this more salient. And it's not true for everybody, but is the idea of maybe you've had a friend who had an accident or had a cancer scare and maybe had a double mastectomy. Does that make her any less of a woman in their mind because she doesn't have the genitals that they connect with her gender identity? And the same could be true with any set of genitals or gender identity. But you don't need to have the biological marker to say, well, this is how I feel in terms of gender. And it would at least help a little bit of a connection to snap there for some parents. All right, I want to talk about, so we were just talking about language and terms and things like that. So why is it important? Language is powerful. I think you hear arguments about PC culture and things like that. People saying, well, maybe just don't be so sensitive. And I'm not here to tell you how to behave in your personal life. That's up to you. I have preferences, but I think we're here talking about clinical environments. And so most of us are probably practicing with some sort of license or accrediting body. And so the truth is we don't really have the option as clinicians to say, well, get over yourself, like stop being so woke, because we have ethical codes, we have accrediting and licensing bodies, and we even have laws that don't give us that luxury. However, there is other reason why language is powerful and why we want to use inclusive and affirming terms. And I think one of the first things is if someone's coming to you as a patient or a client, they're in a vulnerable state and there's already a power differential between you and them showing up. And so someone who's disclosing their identity to a stranger, or especially a stranger who has power in the situation, that person is going to be sensitive. They're already in a sensitive state. If they're seeing us, it's not usually because they're in the best state of their life and just wanted to see us to say, hey, they're already in a sensitive state. And so if we choose to say, you know, get over it, buck up, all of these types of things, that's in terms of developing rapport with your patient or your client, you're not going to do yourself any favors. The other thing to think about are that associations are made really early on. So anyone that's watching this or here right now that works with youth, something that you might consider as a joke or something that you weren't being serious about, that's going to go over the head of a child. And so they're making connections in their brain as they're developing as to what means what. These associations and the schemas around them can develop into a lot more as they grow up, and especially as they become more concrete. To be able to think around that or to work around that as an adult when maybe you've made these associations and they've really been strengthened as a youth is extremely difficult. And so I think that's something else to consider, of whether it's a joke or not. Think about who you're saying it around, because they may not understand the difference. Here are some examples, you might have been reading them while I was blabbering on, of what you might say instead of something that someone might consider to be offensive. And it's really not that difficult, I think, to switch it around, but it can be uncomfortable at first, especially if it's not part of your vernacular, or it might not be just what your habit is. which can be difficult to change. So you might not mean harm and you say something that you've been saying for years and years and years, and the terminology is always changing. And so to keep up with it is difficult. And we'll talk about a little bit later on what to do if you find that you did say the wrong thing, and how to just kind of correct yourself and say the right thing in that moment. Any questions before we move on from this slide? Okay, so language is powerful. A lot of people are identifying as LGBTQ. We never know who's going to walk through our doors. The other thing to keep in mind is that there are pretty large health disparities in terms of physical and mental health with the LGBTQ community compared to their majority counterparts, whether that's cisgender individuals or heterosexual individuals. Here's a list of some. Honestly, the list goes on and on and on and on. And so I'm curious, before I give away the answer, if anyone has an idea as to why the health disparities are so rampant in the LGBTQ community. And I'll give you a clue. And it has to do with the difference between a health disparity and a health difference. And that health disparities are preventable differences in health status, or in the distribution of health resources between different population groups. And this arises from social conditions in which people are born, grow, live, work, and age. So I think actually I gave away the answer in that. So stigma and access to care. I want to think about a specific example. So cancer is on this list. Can anyone think about why people in the LGBTQ community might have higher rates of cancer than in heterosexual communities or cisgender communities?
I know a couple. I mean, I know that minoritized individuals often live in physical environments that are not always safe. I'm thinking urban areas where there is more environmental things that cause cancers. And then as well that HIV/AIDS can also contribute to some cancers as well. So there are some health things there.
Yeah, absolutely. There are quite a few reasons. So homelessness, I'm not sure if it's on this list, is another one, and access to affirming and quality care is another health disparity. And so for somebody who is living on the streets, you're not going to have access to maybe the healthiest foods. Substance misuse is another one that is on here, which can contribute to some cancers. But the other problem is even if somebody realizes that I think something might be wrong, there can be a fear, especially with certain generations, of going to doctors who maybe in the past have given them poor quality care because of their sexual orientation or gender identity, or have been discriminated against by the healthcare community, or because of stigma in the healthcare community are misdiagnosed. So there are a lot of reasons. But I get that question with some of the more physical health disparities as to how could that be? So thank you, Dakota. All right, let's move on to what we can do as clinicians to make our environments more inclusive. I think you'll be surprised kind of by how simple some of these recommendations are, but that many of us aren't doing. But it wouldn't be that much that would have to be changed in a clinic or in an environment. And that's the purpose. We're really not asking people to go get educated and become trainers and then come back and then teach all of the staff and other clinicians about all the health disparities and terminologies and things like that. That's probably not realistic if you have a full caseload. You're probably already working more than 40 hours a week. So what I'm going to introduce here are small things that you can do that'll make a big difference. The first one has to do with interpersonal communication. So this might seem common sense, but when you're in the moment, I think a lot of our natural responses are to get defensive if somebody brings up the fact that we misgendered them, or we used one of those offensive terms that I had listed before on the list of what we say and what we could say. Really, it doesn't need to be a big deal. Honestly, I don't think anybody wants it to be a big deal, especially the person who was offended in the situation. So 3 steps in what you can do in most situations. And of course, this isn't true in every single situation. But the first one, genuinely, succinctly apologize. It doesn't need to be a drawn out thing. I think we've all experienced those apologies and they're so uncomfortable. Just a genuine, succinct apology. And then correct yourself. This might be from that list that I had showed before. So maybe if you knew the right thing to say, but just out of habit, maybe you're busy, you said the wrong thing, and you already know what to say, apologize and correct yourself. If you don't know what exactly it is that you did wrong here, or you don't know what the right thing to say is, ask. And I think this, in another slide, we'll talk about cultural humility, but approach it with curiosity instead of getting defensive. Don't expect the person to teach you the whole history of the reason why and everything like that. That's not their responsibility. That's going to add to their stress. Just assume that they know how they want to be referred to and how they identify, and trust them in that way. And then move on. You don't need to linger on it. Move on. Everybody's ready to move on and wants to move on in most situations. And so I know it might seem simple. You saw in my resume, or the brief description of my resume related to these topics that Annie gave you. I've worked with many, many clients who identify as LGBTQ. And so that means I've stepped in it a good number of times. And typically when I follow these 3 steps, it goes very smoothly. I can think of a specific example of when the pandemic hit and everyone was moving to seeing their clients virtually. And I had a new client coming on, and we all have our little names at the bottom, which is so fantastic, because when we're all in a space together and maybe there are 70 people and I know 10, I can still call people by their names, which is great. However, one of my new clients still had their dead name on their Zoom account, and it was because they were using it in a work environment that they didn't feel safe. And so they had introduced themselves with their affirming name and the name that they go by. And at the very end of our meeting, I read the name on the Zoom screen. I was like, all right, thank you so much. It's been such a pleasure getting to know you over the past hour. Have a good one. And I called them by their dead name and we signed off, and I was horrified. I was sitting there for an entire week like, oh my gosh, they're not coming back next week. What am I going to do? But they did. And at first, one thing that I thought was maybe they didn't notice. Maybe I don't need to bring it up. But I did, because it'd been eating away at me for a week. And of course, my client noticed. Of course they noticed. This is a sensitive thing when you're bringing it to somebody new. You're going to be picking up on all the different cues to try to assess whether it's an environment that's going to work for you and give you the quality care that you need. So they noticed, and they really appreciated that I brought it up. We were able to talk about it for a couple seconds, and then we both moved on. And I'm really glad that I did, because I think overall it helped with our relationship and where it went from there. I'm wondering if anybody else is comfortable sharing a story like this. Have you ever had a moment where maybe you stepped in it and you were able to correct the situation using any of these? Or maybe not, maybe it was a nightmare, or you did these things and it didn't work.
I can share because you presented on this a couple of weeks ago, and so I took this to heart, these steps. I have a LGBTQ client that I work with, and in past sessions, they had talked about a friend using she, her pronouns. And then in my last session with them, they corrected me and they were like, they, and I was like, okay, do they, whatever. And we just moved on, but it was just like a really simple correction. And now I remember moving forward that this particular friend now uses they, them pronouns. And so we're able to kind of just continue talking about things. And so I appreciated that my client, corrected me and was like, no, this is how they identify, and that we can be affirming in that space for not just my client, but also her community as well. So.
Absolutely. Thank you for sharing, Dakota. And I'm sure that they appreciated that a lot more than maybe hearing about, well, my generation, or, well, the way I was raised, and trying to give your whole personal history in terms of defending what you did and why you did it. I think it was probably a lot easier for both of you to just say, oops, I'm sorry, I'll do this moving forward. Anybody else? All right. So on the note of pronouns, thank you for the transition, Dakota. I swear I did not pay her to do that. So pronouns, I think that pronouns can be a touchy subject for a lot of people, just because it might still be something people are getting used to or getting familiar with. And that comfortability takes time and it takes practice. So kind of leaving your comfort zone is the first step in being able to develop the habit and the comfortability around using your pronouns, and using maybe pronouns that you haven't in the past. But they're not really optional. I mean, I shouldn't say really, they're not optional at all. We use pronouns every day, all the time, to refer to each other. And they convey respect. So I think this goes back to my point about the relationship that we're forming with our clients and with our patients. In the way that we decide to refer to them as they asked or not says a lot about our attitudes toward them as a person. I think we've all probably heard the horrible term of when somebody is trying to get used to the using they as a pronoun. And maybe they'll take those first few steps of apologizing, oh, I'm sorry, they, but then follow up with, is it they, it, like going so far as to refer to somebody as not human, as an object. And I think we've all probably heard that, which is unfortunate, and I think just goes to say how important the pronouns are in terms of conveying respect, especially for people who identify as gender diverse, because that has so much to do with their identity. So how do we ask? How do we find out? How do we not make that mistake? First, you can just ask, what pronouns do you use? What are your pronouns? And making that a normal part of conversation is going to make you feel more comfortable about it. And then it's also going to make the way that you ask come off as more genuine and more comfortable. I know that when I first started using my pronouns, I'll be honest, it made me uncomfortable. I was like, and I don't know why, honestly, when I look back on it, I don't know why. I guess it was just because it was something that I wasn't used to doing. But there are also small steps that you can take in terms of making yourself and maybe your staff or other clinicians that you work with more comfortable. Maybe you can start with including a little space on forms that everybody fills out when they come into your clinic that ask for pronouns. And then you can take a look at that sheet before you ever even meet with your client or patient. And then you know the pronouns to use without having to explicitly ask. What about conveying your own pronouns? Does anyone have ideas of maybe how to do that? I know Dakota and I have 2 examples.
Yeah, our Zoom. I have this little pin on my lanyard that says she, her, hers on there. And that's nice, especially when I'm like out and about doing more community-based things. I think that that's really, people notice, you know, even though it's just a small navy button, people notice.
I was gonna say my email signature has mine, and I think on Canvas it has it. And first day of classes, we all go around, introduce ourselves, and we have to say, you know, our pronouns. So I think that's important.
Yeah, awesome. Both of those are 2 of the examples that I have on here. So, I mean, you can use them just whenever you introduce yourself. And then again, I think people have different levels of comfortability, and that's okay. But there are other ways to do that, like in our Zoom names, on Canvas, your email signature, how you sign off on paperwork and things like that. And then, oh yeah, and then you all covered pretty much everything. And then pins and stickers, I also had brought mine here to show as an example. And I know the university's been doing a pretty good job about doing this. With our interviews last year. Everybody was given a sticker. Any questions on the pronoun slide? All right, affirming name and legal name. So we talked about this a little bit before. An affirming name is the name that your client or your patient is called. Their legal name is the name on legal documents, or maybe the name that their parents gave them. What we should try to do is call everybody by their affirming name whenever we can. I think one thing that stands out as different for people working in healthcare fields that might be different than giving this presentation to just like any Joe Schmo, is that there are actual considerations about when to use a legal name versus an affirming name that are out of our hands. Oh, and I also want to say legal name, you might also hear dead name as a term that's used, and that's synonymous. It's the name that someone was given by their parents that they no longer go by. But thinking about in terms of working as a clinician or in the health field, or really any helping profession, can you all think of any time when it wouldn't be appropriate to use an affirming name?
It's definitely not appropriate when the person has not come out yet, for instance, to their parents. So sometimes in legal documentation, like
Yep.
progress notes.
Yes, spot on. Absolutely. So if you're working with youth or even adults who maybe have disabilities, it's really important that you make that clear whenever this first comes up with your client or patient of, okay, so when you're in this space, let's talk about the spaces that I'm going to call you by your affirming name. If your mom is picking you up and we're going to walk out to the waiting room together, it's going to hurt. It might hurt. And I hate to have to do this, but I know that maybe you haven't disclosed your identity to your mom because it'll make your home environment unsafe. So I'm going to call you by your legal name when I say goodbye and your mom is standing there. Dr. Smith, you had also talked about certain medical records, progress notes, things that parents have access to or can get access to should always be on your mind. And I think it's important to let your client and patient know the boundaries that you have to set for this and why you're doing that. That overall it's to protect them. And then beyond that, for just some logistical financial reasons, insurance companies might also require legal names. And while it's frustrating, I think that the coverage is going to be pretty important. And so there are occasions when you might still have to use a legal name versus an affirming name, but anytime you can use the affirming name, and then just have the conversation with your patient or client. It shouldn't be a surprise to them if they see or hear you using their legal name. Any questions on this slide or other suggestions? All right. Fluency of terminology. So we went over some terms, but it's impossible to know everything. It is absolutely impossible to know everything. So you should definitely always try to familiarize yourself with whatever the current terminology is. It's always updating, it's always changing. Some things that maybe are considered okay one year are offensive, the next things that are offensive at a certain time become not offensive later. Some people can use some words, some people can't. And so I think what it might do for some people is scare them off completely. Not wanting to bring up the subject or ask about certain things or say certain things because they're afraid to get called out or to make the mistake or sound dumb. I don't think for us as clinicians, that is an option. Again, we don't have the luxury to just avoid the topic because we think it's taboo or because you're afraid. The terminology around LGBTQ life is important. It's important to know sexual orientation and gender identity in terms of case conceptualization, treatment plans, and then also just getting to know your client or patient as a human. That's part of their life, that's part of their identity. And so it's not something that should be ignored because you can't keep up. So what should you do if you can't keep up? You should do your best, but I understand, again, everybody's busy. We're all so busy. And so when you're meeting with a new client or a new patient, approach them with cultural humility. And this is that idea of approaching with curiosity. And I think maybe a lot of us already do this in our work or should, but we're the experts on some things. We're not the experts on everything, and that's okay. Don't let your pride get in the way. I think one thing when I meet with clients, whether it's in clinic that specializes in LGBTQ issues, or it's just a whole community clinic, I like to introduce what we're doing as team-based. I have knowledge in this area, but you have knowledge on your life and all of your identities and all of the things that you've experienced. And for me to come up with a treatment plan in a silo without your input is kind of silly. So I think it's important to just ask your client about the terms that they use, that they prefer for you to use, especially how you should refer to them in terms of pronouns and the name that they want to be called. And then I have a link here. So Annie, maybe you can share the slides out with anyone that registered for this, because also my last slide has resources, and you can find a list that has updated terms as they're ever changing. Any questions?
We can make sure that we add that link in the description for the video when I upload it to YouTube.
Perfect. Yeah, that would be fantastic. And there are a few other links at the end that are connected to resources. All right, this is the last slide talking about what we can do. And this just has to do with how we are decorating our places, how our buildings are designed, and what we can do to show that representation that I was talking about at the beginning, that's helping to change the how people perceive others who are part of the LGBTQ communities. And then also how to reduce anxiety prior to and during a visit for any clients or patients that you have who identify as LGBTQ. It might also help bring to light really important information, because if a client sees that your office has that little rainbow sticker somewhere, then they might feel more comfortable opening up in the first visit versus the fifth. And there might be information there that's really crucial. And so it might also help your clients or patients to feel like they can be honest and be themselves with you. And it's probably going to give you a little bit of boost in terms of building rapport with your clients or patients, which I think we all know is very important. So waiting areas. These are places where people spend a lot of time, unfortunately for them. So things that you can do is have magazines out, art on the walls that depicts maybe same-sex couples or more androgynous people in the pictures, books covering these topics, just kind of sitting out, spread throughout with other materials. I have some examples of things. Also in your offices, I know a lot of people have these ally stickers around USU's campuses that they put outside of their offices, which generally show students that this is an accepting person whose office this is. And then bathrooms, having gender neutral bathrooms is really helpful to reduce anxiety for your clients, knowing that they have somewhere to go. I have some examples of things that I have around my office. So like these stickers, I have this fun Utah one. And then the allies one, like I was mentioning, my he, him pin, and then just other materials, books for kids, A Day in the Life of Marlon Bundo about 2 gay rabbits, and then things that are for me that you'll see on the shelves, mindfulness, and then also reading for adults if they're interested, looking at the history of homosexuality in American culture. Little heavier reading. I'm not sure who would actually ever read that in the waiting room, but it's there if someone's interested. I'm curious if anybody here has things that maybe I haven't mentioned or talked about that they're using to decorate their offices or that their clinic does.
I think the hard thing about being at the Sorenson Center is that there's a separate clinic space separate from my office, because I do have this little guy in my office. So just fun little, because I love plants. And so I think I got the flag at like the Pride Festival once or something like that, right? So, but like people don't see that because clients don't come to my office, which makes it kind of tricky. So I think that's a little bit harder, at least in our space, just because it's so like neutral. Like there's really nothing in the waiting rooms actually. Like it's just green and black and gray, like as far as furniture and pillows.
Yeah, definitely. And I mean, you're doing what you can in the space that you have. And so if clients aren't coming into your office up there, at least everybody else that's coming in there, without you having to say it, you have an item that people know what it means and represents that you are an ally or this is a safe place for them to be. So yeah, that's fantastic. The pride flags are another great thing to use to adorn your spaces with. Okay, so that was what I had to go over. And our manual, while it's not specific on just clinical environments broadly like this was, it is a bit more narrow. It also goes into these things deeper. So if people are curious about more of that stuff, you can ask now. You can reach out to me later, Annie, if you don't mind including my email in wherever all this stuff ends up. People can always shoot me emails to talk more about what this could look like or bounce ideas off of each other. All right, thanks everybody.